Hello, my name is David Bishop and I'm a specialist anaesthetist, and today I'm going to have a look at a very simple approach to a general anesthetic which is aimed at district hospital level. General anesthesia is a complex process with lots of moving parts, and I don't think any specialist anaesthetist will ever use exactly the same recipe because patients vary and procedures vary. But I'm going to end with a recipe that it's as close as I can get to a beginner recipe that will work even if it's not the most elegant anesthetic in the world. And I want to encourage 3 areas where you need to grow your skill set. And this may sound very basic, but the first of them is the pre-operative evaluation. And it's an area in which district hospitals have the clinical skills and the tools that are necessary. But it often gets neglected, maybe because of busyness or because of task sharing, etc. But if you're a beginner anaesthetist, you really need a good pre-op assessment. So don't fall into the trap of going and anesthetizing an unassessed patient, because this is one of the things you can control when you take these patients to theatre. Now, it doesn't have to be exhaustive, but every patient has their own fingerprint. Make sure that you check their vital signs: heart rate, blood pressure. If you can get them SATs, have a look at the respiratory rate, look at the level of consciousness, maybe get a temperature. Those things are available. Check what they are. If there are any investigations that have been done, do you have a ward hemoglobin or a glucose? Check them. Sometimes you have access to a blood gas. Have a look at it. If you've done that, look at what you've got available. Not every patient needs all of these things, but these simple things are available to you. And then make sure that you examine the airway specifically and that you listen to the heart. And finally, when you're looking at patients, remember what procedure are they having. And sometimes the patient may be healthy, but the procedure that they're having, for instance, a general anesthesia for a placenta accreta spectrum, that patient could complicate on table, and that will affect how you give your anesthetic, and it will affect how you set up. When you examine the airway, and there's a separate video that I've done on looking at airways, just remember you're looking at 3 components. Will I be able to do mask ventilation? Will I be able to do laryngoscopy? And can I insert a rescue surgical airway if necessary? And there are mnemonics for the first 2, and I'll show you where those talks can be found a bit later. But remember that for each component of the airway, you need to specifically assess it. And get used to doing this. This is an easy assessment, it takes a couple of minutes, and it really helps you prepare properly. The second set of skills is preparation. And again, this is something you can control. You've won a lot of the battle if you induce an assessed patient in a prepared environment. So do it. It's a discipline, but it's absolutely vital. And then once you've assessed the patient's conditioning, decide how that condition and the procedure you're going to do will alter your theatre preparation. And theatre setup is about equipment, drugs, staffing. Have you got the right staff? Have you got the right resources available? And which drugs should you draw up, not have available? Do you need adrenaline drawn up before you start? That sort of thing. So it's vital to make sure that the room you're going into is adequately prepared. Now, in terms of drugs, these things are available through the ESMOE guidelines. These should be laminated and up on your walls. You don't have to remember doses. You can be told which ones should be on the wall. We've also got videos on how to draw up emergency drugs, which I'm not going to go into today, but those are available on the YouTube site. Again, for essential equipment lists, those are available through ESMOE as well. And you keep one of these on your wall, and then sometime when you're not anesthetizing, you make sure that all of these things are in your theatres, so that when you come in with an emergency or a general anesthetic, you know those things are already there. So this is the sort of thing that needs to be allocated to a single medical officer who can be responsible for these things within your hospital, or for at least for checking them. Remember that your airway trolley needs to be set up appropriately. You need a working laryngoscope, ideally 2. You need different size intratracheal tubes, Guedel airways, and in particular you need a supraglottic airway device like a laryngeal mask or a ProSeal or an iGel, probably a size 3. And you must check these things. Again, we've got a short video on how to check the airway trolley. That's 5 minutes. So when you're not sure about these things, go and watch the video and make sure that you can check an airway trolley. And in all of these things, the first time you do them, it's quite a lot to remember. But if you've done one, you can think, oh, well, I didn't check the airway trolley as well as I should have. The next time you do that properly. And you layer your knowledge until these things become just an integral part of your practice. Machine check. The most important thing is you start doing one. This is obviously a machine that would fail its check. It's not plugged in. There are no gases on it. There's no circuit. There's no vaporizers. But make sure that you learn how to check an anesthetic machine. And again, we've got a talk on how to do this, but it's pitched at a diploma of anesthetic level, that talk. It's 12 minutes. You basically need to make sure you can switch these machines on, detect basic leaks. You know how to ventilate manually. You can ventilate with invasive, with controlled ventilation. And you need to get to know this machine. It's your friend. But if you're going to come into a room and you don't have time, there's certain things you must always do, even when you're rushed. The first is to check you've got a working ambu bag. These things are sometimes present and don't work. So make sure that you put that airway over your hand and occlude it, and you press the bag and see that you can generate pressure. You must check them. The second is a backup oxygen cylinder. Most of your district hospitals are running off a cylinder manifold, which relies on somebody checking these things and replacing them. So it's the sort of thing that can go wrong. And it's very hard to do a general anesthetic without oxygen if you run out. So check your reserve cylinder. And perhaps most importantly, make sure you've got some form of suction in the room with a Yankow, some way of suctioning the airway, because if a patient vomits and you need to intubate them, it is impossible to do it without suction. It's probably the piece of equipment that I get most anxious if it's not working, because there's very few remedies for that. And just to remind you, the anesthetic machine check, there's a 12-minute video by Garth Horston, who's a specialist anaesthetist in private, who will run through a very thorough check on how to do it. And then just so that you have options for other approaches, that's Andrew Levy in the second video doing the basic general anesthetic, and he runs through a more detailed way to do a general anesthetic than I'm giving you today. So if you listen to this talk today and you think I want more substance to it, Andrew gives a very nice approach to make sure that you haven't missed anything out. And it's 13 minutes. It's a nice mnemonic-based recipe. And then finally, doing the general anesthetic itself is the third skill set that you need. And for most people, they worry about intubation and ventilation. I just want to make the point that when you're giving an anesthetic, it is a very bad idea to have your cell phone in the room in a way that you will pick it up and check messages or check whichever social communication app you use, or check the news. It's a habit we fall into. We pick these things up and we look at things that aren't related to the anesthetic. Put it away. You need to stay alert and stay vigilant. Not necessarily anxious, but you've got to be constantly watching your anesthetic and tweaking and tinkering and making sure you haven't missed anything. And I don't even sit down during an anesthetic. I spend most of the time on my feet. I'm always watching my anesthetic, and I just try and get that phone away from you. Now, a general anesthetic is very simple in concept. You prepare the theater and you position your patient appropriately. You give them an induction agent, you intubate them and put them on the ventilator. You maintain the anesthetic and give them something for pain while they're asleep, and then you wake them up. So it's quite a simple idea that we're trying to get across. But the thing that scares people is that step, the induction and intubation and ventilation. That is probably the most scary part of an anesthetic. So find ways to practice what scares you. So for intubation, make sure when there are mannequins around that you intubate them. When there are resuscitations in your hospital, always intubate the patient during the resuscitation if you can. When anesthesia in-reach comes to your hospital, or outreach comes to your hospital, make sure that you're practicing your intubation. If you know how to do it, make sure you're teaching someone that doesn't. And then for ventilation, put a false lung on the ventilator, which is just another bag. So stick it on the end of the anesthetic circuit and try and set your ventilator. Make sure you've done this before your first general anesthetic on a machine, and play with the different ventilatory modes to make sure that you can ventilate a false lung. It's really easy to practice, and really, because it's so easy, it's not really an excuse that the first time we're learning how to use a ventilator is on a patient. Now we've, myself and Simon Leroux, have written this article on how to do anesthesia for ruptured ectopic pregnancy at district level. This is aimed now at a sick patient who's had a ruptured ectopic pregnancy. But why I'm referring to this article is that we've put down the basic principles of an anesthetic in a one-pager. And you can print this out and laminate it and stick it up on your wall, or at least look at it and see where it's useful. And this is something you can refer to as you're going along, and it'll give you every component, just a very, very simple overview. So for instance, this is the sequence: you pre-oxygenate, you induce, you paralyze, you intubate, you maintain, remember analgesia, and you reverse your muscle relaxation and extubate. It tells you what monitoring, how to do IVI access, how to fluid resus, checking the ward HB, have you got a warmer, remember that your anaesthetist is not task sharing, they're dedicated to the anesthetic only, and the little checklist that you can use. It then takes you into induction, some of the options. Now, this is the basic approach to putting someone to sleep. You first need to choose an induction agent. You just need to choose one of those. Now, your hospital might have a range: ketamine, etomidate, propofol, thiopentone. Those are probably the main ones. Thiopentone is becoming less available, so you're probably choosing one of those three. And if you were only ever going to choose one, that you've only got one, you'd probably choose ketamine, because it really can be used with sick patients or healthy patients. It's not the most elegant anesthetic. I tend to use propofol when I have a choice, but if you're only going to get used to one, start with ketamine, because you can use it in any scenario. When you're paralyzing the patient to intubate, succinylcholine is probably the one you want to learn on, 1 milligram per kilogram. That will allow a rapid sequence induction, but you can use rocuronium, cisatracurium, vecuronium, all of those other non-depolarizing muscle relaxations, but they add a level of complexity because you must reverse them. They all have different durations, whereas if you use ketamine and succinylcholine, your muscle relaxation is going to last 5 to 10 minutes in the majority of patients, and that's very, very simple. And then you've got to maintain anesthesia, and again, you can use a volatile, a gas, or you can use ketamine boluses, but it's quite simple just to use isoflurane and turn it on in the range of about 0.3 to 1, depending on how stable your patient is. Stable patients need more gas, sick patients need much less gas. And you just titrate that to the blood pressure. Your muscle relaxation wears off, so if the patient moves, you deepen them by increasing the volatile anesthetic. And that is a very simple approach to an anesthetic, which I think most people can remember: ketamine, succinylcholine, gas. So another way to put that down is you start with ketamine 2 milligrams per kilogram, followed by succinylcholine 1 milligram per kilogram. Turn your isoflurane on at 0.3 to 1, and you can use ketamine boluses if you prefer, 1 milligram per kilogram as needed. And then think about your hemodynamic targets. Try and keep your heart rate below 120, the patient's blood pressure above 90, and the hemoglobin above 7. And that really is all you need to do. When you intubate, put in something like a size 7 or an LMA if that fails, and then dial in set values that you're used to. This is now the ones we put up there for a ruptured ectopic. I'll come to some different ones just now. But remember that the goal is oxygenation, not intubation. So you're trying to get oxygen into those lungs, and if you can't get an endotracheal tube in, do whatever you can to get oxygen in. And that might be a laryngeal mask, an LMA, or a ProSeal. It could even be holding a mask. You've just got to get that oxygen in and out. So you want to ventilate with oxygen, and intubation is the best way to do it, but there are other ways. Now, a note on Airway: there are a lot of resources. This one is particularly good, everything you need to know, sometimes more detailed than someone will need in a district hospital. This is Professor Ross Hofmeyr. He's the airway expert at UCT, and he runs a website called openairway.org. Lots of videos. You can see there he's doing an awake fiber optic intubation, which is something any airway person worth their salt apparently does. I have not done this. But if you go there, there are lots of nice resources for how to manage an airway. We've also published a few videos: the airway trolley check, how to take an obstetric GA from intubation to ventilation, Dr. Tomlinson has done one called the Obstetric Airway Bundle, which is really, really good. It's 16 minutes and it just looks at various interventions for an obstetric airway. And then I've done a video called Intubation, Getting It Right, which is a more detailed look at your technique. So go and check these ones out if you're interested in the specifics. Just to run you very gently, very simply through the process, make sure you've positioned the patient right. Always position the patient as if the airway is going to be difficult. And the more of a beginner you are, the more important this is. It's probably the most important thing you do. You have to get the positioning right. So if you look at this patient's going to be difficult to intubate because you can't get around the corner. So either stack them up on pillows, so you see how that head is in the morning sniff position, it's been pushed forward and now that intubation is much easier, or you can use the bed and you break the bed like that and you get the same position. But get that position, look from the side and make sure you've got that head slightly extended and pushed forward. It'll make your intubations much easier. So position every patient properly. Get your technique right, and if you're not sure, have a senior there just until you've put the patient on the ventilator. 2 experienced hands in the room really, really help. So key things there, lift up and away once that laryngoscope is in the right position, and don't rotate your wrist. You pull it upwards. Remember that the burp maneuver is really helpful, so this is something you need to tell your assistant to do, and they need to be told while the patient's awake before you start. And that's grabbing on the thyroid cartilage or the cricoid ring and pushing backward, rightward, and upward. That's called a burp maneuver. That's spelled BRUP in this slide, but we call it a burp maneuver. And the idea is that you push that larynx into a better position so that you can have a look with the laryngoscope. You can see it. So you can literally have your laryngoscope in and then you ask them to manipulate that. You can even push it into position and then they hold it there. And an airway can go from that where you can just see the bottom of the airway to that where you can see the vocal cords. That's what a burp maneuver will do for you. When you're actually intubating the patient, start with a curved blade. It's more forgiving of an imperfect placement. It's a stepwise progression with each step having the goal of identification of structures. So you open the mouth, insert the blade without dental damage, tongue sweep to the left and advance. And what you're looking for is not vocal cords, you're trying to identify the epiglottis. Once you get it to the base of the epiglottis, you get the tip to the base, that's called the vallecula. Only then do you lift up and away. And once you've lifted up and away, you can get someone to do a burp maneuver, and then you watch the tube go through the cords. And here's a video of that just to remind you. So the laryngoscope blade tip is going in. Tongue sweep hasn't been ideal. Going down to the base of the epiglottis, that is the epiglottis, and you see how that tip is right at the base, and that's called the vallecula. That's where you want your tip. Now this person keeps looking for a slightly better position. That's a good position, but then they push it too far. Now they've gone past the epiglottis, so they bring it back. Now you've got it at the base of the epiglottis, and then you can lift up and away. And you can see now, we can see the vocal cords and the glottis, and we know where to stick the tube. The tube now must be put through under direct vision. You see it go through the cords. There goes the balloon. Now this person's pushed it too deep, and when you're struggling with an airway, you'll often push it too deep. So you have to pull it back, and the thing mustn't go past the second line. So get that at the right depth, and you must choose depth under vision. You decide what the right depth is under vision. Once the patient's intubated and you have connected, then you connect to the ventilator, and you start with a mode of ventilation that you're comfortable with. Most people find volume control ventilation the easiest to understand, so set it at something like a tidal volume of 400 mils, a respiratory rate of 12, a PEEP of 5, and an oxygen of about 40% if you've got a stable patient, probably 100% if you don't. And remember that you probably want to choose a synchronized mode. And what a synchronized mode will do is it'll give you the 12 breaths that you need, that you've asked it to give. But if the patient starts to breathe, then the ventilator will synchronize that breath with the patient's effort. And when you use a recipe like I've suggested, where you use succinylmethonium, after 5 to 10 minutes, that patient may well start breathing again. And then you just get the ventilator to time its ventilation with the patients. If you need paralysis for surgery, then you have to give another muscle relaxant. Then the ventilator will continue to do its thing, but at least this allows it to synchronize if the patient breathes. So get used to synchronized modes when you set up the ventilator. And then that's maintenance anesthesia, which we've covered. Just remember that you need to add analgesia to this. So generally morphine is the one you'll be comfortable with, and if you've got paracetamol, add it. But if the patient's very unstable, I might substitute fentanyl, something like 1 mic per kilogram every 30 minutes, so 50 mics every 30 minutes, or you could use ketamine boluses. When you wake the patient up, remember the patient needs to be hemodynamically stable, not on adrenaline, oxygenating well, reasonable hemoglobin, not cold. And if you have given one of those non-depolarizing muscle relaxants like rocuronium or vecuronium or cisatracurium, then you need to reverse with glycopyrrolate and neostigmine. And in most cases in district hospitals, do awake extubations. Extubation has a complication rate that's 3 times higher than intubation. So the easiest way to avoid those complications is to make sure the patient's wide awake. They've opened their eyes, they're obeying commands before you pull that tube. Because often people pull this tube when the patient's not quite awake and they go into laryngospasm, they obstruct the airway, and you can actually have a lot of difficulty at this point. So the safest thing is to do awake extubations, even if it's not the most elegant. And remember to use that recovery period to your advantage. So use the full 30 minutes or more. Make sure they're fully conscious, they're hemodynamically stable, they're not tachypneic, the pain is controlled. This is the last time that you'll have a really good monitored setting in a district hospital. So use it to make sure your patient is stable. And if you're not sure when you sign that patient out, schedule a post-operative visit. You can go and pick up if there are any complications. Now, I promised a one-size-fits-all recipe, and I'm hesitate to do this because in practice I almost never give an anesthetic this way. But if I had to tell a beginner over the phone what to do, this is probably the recipe I would give that person. But if you're not sure, ideally you phone someone and we'll add maybe some subtlety or some nuances to it. So the first thing is that I would examine every patient and I would prepare every theatre. I would put monitors on the patient and I'd make sure I had a good working IVI line. I'd position the patient as if they had a difficult airway every single time. I would pre-oxygenate for a full 4 minutes with 100% oxygen, just to buy me time while I'm intubating. And then I would give ketamine 2 milligrams per kilogram. If you're not sure, you give 100 milligrams of ketamine IVI. I'd give succinylmethonium 1 milligram per kilogram, something like 50 to 100 milligrams of succinylmethonium. And then I would intubate with a size 7 endotracheal tube in most adults. I would ventilate to keep the carbon dioxide at something like 4 to 5 kilopascals using an SIMV mode with those settings that I mentioned earlier. I would maintain anesthesia, and I usually run an end-tidal isoflurane of about 0.8, depending on the stability of the patient. I'd give analgesia with morphine 5 to 10 milligrams. I usually use 10 milligrams in an adult. I might supplement it with a bit of ketamine if the patient was unstable, or even fentanyl, as I mentioned earlier. At the end, I would switch off the gas and I would extubate the patient awake. And the only proviso I would add here is that if I'd given a non-depolarizing muscle relaxant, then I would give reversal before I extubated the patient. I'd make sure that patient was reversed either with a nerve stimulator. But if you don't have that, at least make sure the patient's moving, lifting their arms, able to lift their heads before I extubated that patient. This is probably the closest I can get to a one-size-fits-all, but remember that before you start, if you've got time, you can always phone someone. And when you phone someone, they might say, oh, in this patient, I would tinker like this, I'd tweak your anesthetic like this. But this recipe, if you just do this in all your patients, you'll probably find that it's fine, and you can add the subtleties to it as you get more experienced. And that's all. Thank you very much.